etch starts in the pits and fissure sealants. Although fluoride treatment are most effective in preventing smooth surface caries, they are less effective in preventing pit and fissure caries. Occlusal surface in children's teeth were 5 times more likely to be the site of caries than in proximal surfaces and twice as likely as facial or lingual surfaces. And so, preventive measure for its pit and fissure caries is greatly needed. Pits and fissure sealants are specially designed for this purpose and have been shown to be effective. In sealants, there are 3 important preventive effects. First, sealants mechanically fill the pits and fissure but with an acid-resistant resin. Second, because pits and fissures are filled, then the sealants deny the cardiogenic organisms such as Streptococcus mutans and the others their preferred habitat. So if there will be no place for them to live or to survive, then there will be no progression of the caries. Third is the sealants render pits and fissure easier to clean by toothbrushing and mastication. However, pits and fissure sealants is not yet in total acceptance of the community, especially here in the Philippines. Dental health in general is not really a priority. And so, when in fact, in 1986 to 1988, National Institute of Dental Research indicates that only 1 out of 5 children had sealants. In conclusion of that, if only more children receive sealants, caries prevalence would reduce. Sealants have been shown to be effective, to have long-term retention, to cause regression of active lesions, and to be superior to amalgam restorations in terms of time requirement. When sealant is lost, it is most likely a result of technical error in application rather than a result of poor bond strength. Proper acid etch bonding of the methacrylate and resin polymers to enamel produces a bond strong enough to retain the restoration, orthodontic brackets, and prosthetic bridges. So in order to prevent the failure of retaining the sealant in the affected tooth, the dentist should properly isolate the tooth when etching and bonding it to avoid saliva contamination. If sealant loss occur, sealant should be replaced in patients who remain in high risk. The next clip shows how the pits and fissure sealants are applied.
First, indicate the teeth that sealants would benefit. Clean the surface from debris, stain, and calculus. Isolate the tooth with options such as the suction, cotton rolls, or dry angles. Dry the area for 20 to 30 seconds. Apply acid etch within the grooves and fissures where the sealants are to be placed, based on the manufacturer's recommendations, which are from 15 to 30 seconds. Rinse for 30 to 60 seconds. Dry the area for 20 to 30 seconds. The tooth will have a chalky white appearance when fully dry. If not, or if contamination occurs, re-etch. Then re-isolate if necessary. Place the sealant material in the pits and fissures only. You may have to use a microbrush to remove any bubbles and to remove any excess material. Using patient and clinician UV protection, cure the sealant material as per the manufacturer's recommended amount of time, usually from 20 to 30 seconds. Gently check for voids and complete coverage with the Explorer while maintaining a dry field. If at any point you find an issue, you can add additional material without having to re-etch if the surface has not been contaminated. Remove the isolation with a small amount of water so it won't stick and pull the tissues. Evaluate the occlusion with the articulating paper. Overfilled areas may require adjustment with an instrument if using unfilled material, or a drill with use of a filled sealant material. Floss the contacts to ensure material has not flowed into the contact spaces.
The cost of sealant treatment in caries inactive patients are not justified, although sealants are cost-effective in caries active patients. So sealants are not recommended for those patients who do not have signs of caries activity. Sealant prevents caries in newly erupted teeth. It also arrest incipient caries. It also prevents odontopathogenic bacterial growth in the sealed fissure and prevent infection of the other sides. The status of the patient's existing restoration may have an important bearing on the outcome of preventive measures and caries treatment. Old, corroded, metallic restorations that are rough and plaque retentive could be smoothed. It could also be polished or replaced. Restoration defects such as overhangs, open proximal contacts, and defective contours contribute to plaque formation and retention. These defects should be corrected usually by the replacement of the defective restoration. The treatment regimen is dictated by the patient's caries status. If the patient is at higher risk of caries development, the treatment should consist of restorative procedures and many preventive measures. The important thing in treatment success is the patient's education about what has caused the caries problem and what are his or her responsibility. So we as a dentist should always remind and should always educate our patients what to do in order for them to have a healthier teeth, and also the basics such as proper toothbrushing, flossing, and topical fluoride. Intense short-term use of antimicrobial agents should be implemented, especially in high-risk patients. This may include various fluoride modality, chlorhexidine, and sometimes antibiotics such as vancomycin and kanamycin. These antimicrobial agents reduce the number of cariogenic bacteria and makes the tooth surfaces more prone to remineralization. So again, high-risk patients should also be instructed to use fluoride rinses and xylitol chewing gums regularly. Caries control refers to an operative procedure in which multiple teeth with acute threatening caries are treated quickly by first removing the infected tooth structure, second medicating the pulp if necessary, and third restoring the defects with a temporary material. By removing the infected tooth structure, you also remove the infecting or microorganisms. So, if you have already removed the infecting microorganisms or organisms, this also means you have control, or you also limit the spread of the caries throughout the mouth. The intent of caries control procedure is immediate, corrective intervention in advanced caries lesions to prevent and assess pulpal disease and avoid possible sequelae such as toothache, root canal therapy, and more complex restorations. So this always boils down to prevention is better than cure, right? So that's all for my report. Thank you for listening.